Good morning. My name is Dr. Anna Kurian, and first of all, thank you to AIOS, Dr. Mariam Poli, and my mentor, Dr. Annie Sridhar, for giving me the opportunity to present this case. This is a case of a 59-year-old male who came to our OPD with painless swelling of the right lacrimal sac region of 2 months duration. He gave a history of dacrocystorhinostomy with sac biopsy, which was done elsewhere, and the biopsy results suggestive of papilloma. On clinical examination, there was a 5 into 4 centimeter ovoid, non-tender, firm, immobile mass, which was seen extending above the medial palpebral ligament, and the surface of the lesion showed ulceration, probably due to a non-healing incision site, and there were no palpable regional lymph nodes. CT scan showed a homogeneous soft tissue lesion with minimal bony excavation. So with the history of papilloma and the CT finding, we decided to go ahead with right lacrimal sac mass excisional biopsy. However, during the intraoperative period, we found the tumor to be extending into the nasal cavity via the DCR ostium made by the previous surgery. So the mass was sent for histopathology, and the findings were suggestive of well-differentiated squamous cell carcinoma. The final diagnosis was squamous cell carcinoma of lacrimal sac, and the patient was referred to ENT and oncology department, and further resection was done by the surgical oncologist. However, within 1 month of referral itself, there was again a local recurrence at the site, and the surgical oncologist went ahead with wide excision of the lesion with excision of 1/3 of upper and lower eyelids, periorbital fat, medial wall of orbit, medial 1/3 of floor, and medial maxillectomy was done. And reconstruction was done using paramedian forehead flap, tensile rotation flap, cheek rotation advancement flap, and nasal mucosal lining graft. And the histopathology of the final lesion was well-differentiated squamous cell carcinoma. The resected area margins were free of cancer, and pathological classification according to AGCC 7th edition lacrimal gland tumor classification was T4 without any nodal metastasis. The patient is on receiving adjuvant radiotherapy and is being kept under follow-up every 3 months. Now, the highlights of this case was, one, deep incisional biopsy is preferred in case of a suspicious sac during routine DCR. The main reason is with superficial biopsy, you may miss the malignant cells and will only get the inflammatory reaction. Second part is that in case of an inverted papilloma, which is benign, but there is a 7 to 16% of cases, squamous cell carcinoma can occur either synchronously or metachronously. And the second thing is the lacrimal sac fossa or a DCR ostium should not be created in case of a suspicious sac during your routine DCR, because this will aid in the spread of the tumor. First, get the biopsy specimen analyzed and then decide on the treatment. Going ahead with the discussion, lacrimal sac tumors are extremely rare, but they are potentially life-threatening, and around 55 to 100% of the tumors are malignant. So their clinical workup and management is very important. Signs and symptoms suggestive of a lacrimal sac tumor is a chronic nasolacrimal duct obstruction, hemolacria, a mass which is non-reducible, non-compressible of hard mass, and there is sanguineous hemolacria. And late stage, you have signs of orbital invasion suggestive of non-axial proptosis, skin ulceration, and rarely distant metastasis. As you all know, the lining of lacrimal sac, you have pseudostratified columnar epithelium with interspersed ciliated respiratory epithelium, and the nasolacrimal duct has ciliated respiratory epithelium. So you have a vivid number of tumors which can arise from the lacrimal sac. The main is epithelial tumors, which account for 60 to 94%, of which the most common benign is a papilloma, and the most common malignant is a squamous cell carcinoma. Non-epithelial tumors include lymphoproliferative, melanocytic, and mesenchymal tumors. One other point is inverted papilloma, like I said, is benign, but it's a locally aggressive tumor with high chance of malignant transformation to squamous cell carcinoma. And also there is a chance for squamous cell carcinoma to occur in it synchronously or metachronously. Squamous cell carcinomas are highly malignant. They have a 50% chance of recurrence, and 50% of which is 50% of it is fatal. Risk factor for malignant transformation include positivity for HPV, high mitotic figures, overexpression of P53, EGFR, or TGF-alpha. And coming to the management, first is tissue biopsy, and if it's benign and confined to the lacrimal sac, dacrocystectomy is done. If it's malignant, an en bloc tumor excision with maxillectomy is preferred to increase the survival rate, and depending on the extent, resection of the orbital walls and or paranasal sinuses or lymph nodes, depending on their spread. Postoperative radiation is preferred, and chemotherapy in case of recurrent or in case of lymphoma. So for the take-home message, look out for any unusual findings during a DCR and do a sac biopsy, preferably a wide biopsy is required. And the usual unusual findings are one, recurrent DCR, or the patient has, hemolacria, non-compressible lesion, and on table if you find the lacrimal sac to be hardened, it's preferable to go with biopsy at least, and stop doing the DCR ostium. I extend my courtesy to Dr. Sajida and Dr. Anand Ibn Thomas for giving me help, and that's it. Thank you.